including, of course, most importantly, developmentally disabled people. What are the complex factors that go into producing pain problems, chronic pain syndromes, and how can we understand that through the reference frame of different syndromes of developmental disability? We're going to be reviewing individual variables. Why is it or how is it that some people with developmental disability react differently to given kinds of pain issues? What are some of the considerations that contribute to those individual differences? When we have developmentally disabled people taking medications to alleviate pain, unfortunately, sometimes the results are exactly the opposite of what we might hope for. That is, the developmentally disabled person with a pain problem experiences more pain rather than less. How does this come about? And what are the considerations that we need to think about trying to avoid this problem? And because pain is a complex phenomenon, there are different varieties of chronic pain syndromes, different manifestations of the way pain symptoms can be experienced and expressed, and we're going to be reviewing those as well. Are we still on? Yeah. Okay. So I'm going to continue then. So why is it important to focus on pain? Pain negatively affects the quality of life by impairing a number of different areas. For example, daily functioning. Everything is harder to do with pain symptoms. Everything that a person tends to do, whether it's activities of daily living, working, socializing, all of those activities can be harder to do when there are constant or chronic episodes of pain. And there are a couple of reasons for this. First of all of these activities are less rewarding or positively reinforcing when the person is in pain. And over time, motivation can be impaired. Something that's less rewarding tends to be less interesting. We do less of it. The developmentally disabled person will do less of it. And so daily functioning in general is impaired by pain symptoms. Social relationships are impaired by the frequent occurrence of pain in two ways. Again, the issue of motivation. A social relationship is less rewarding, and also motivation as a result decreases. In addition, the person who is in pain is going to have less of a, what we'll say in technical terms, social stimulus value, or in plain English, there's going to be episodes where the person is suffering symptoms rather than paying attention to what they're doing in the social interaction. And so the other party in that interaction over time is going to become more withdrawn, perhaps, or less interested in continuing the social interaction. So social relationships will be impaired by the occurrence of pain symptoms. Sleep quality tends to decline, and there tend to be sleep disturbances as a result of chronic pain symptoms. There was a recent study, in fact, the publication date is 2014 in the journal Autism, where 62 autistic patients who also had pain problems were studied vis-a-vis the integrity of their sleep. And as we might expect, there were various sleep problems with breathing, parasomnias, and other features of sleep disorder noted in these autistic study participants who had chronic pain syndrome or symptoms. Often with the occurrence of chronic pain, there's a problem with decreasing sense of self-worth. All of us tend to depend on having a certain amount of control, or if you want to use a more technical term, mastery in our daily lives to feel reasonably good about ourselves. We expect to be able to have some impact or influence on the experiences we have and on the quality of our daily lives. And when a developmentally disabled person, or anyone else for that matter, has a frequent occurrence of pain symptoms, this has an underlying subtext of a lack of control over daily existence, and that can go on to impair the person's sense of self-worth. The frequent occurrence of pain symptoms will often lead to increased levels of anxiety, irritability, and sadness. So the person's emotional functioning when suffering from chronic pain symptoms is also likely to be negatively impacted. And as we'll detail a little further along in this workshop, there are a number of ways that the occurrence of chronic pain symptoms can worsen the developmentally disabled person's medical condition. So for all of these reasons, it's extremely important to focus on pain in general and adequate management of pain symptoms should they occur. And if we look at the next slide, we can see that unrelieved pain can have enormous impacts in a number of different areas, not only on the patient, which is of course our primary concern, but also on their loved ones and on caregivers. Physiological impacts can include negative changes in the way that the pain nerves function in the developmentally disabled person, as is true for all patients with pain. So that unrelieved pain changes the functioning of the pain nerves over time, causing them to get into a pattern where they fire more frequently and are more difficult to get to stop firing. We'll detail that a little bit later in this workshop. And that worsens a chronic pain problem. There are the psychological impacts that I mentioned a few minutes ago: depression, agitation, anxiety, and increased vulnerability to episodes of anger. And caregivers, in addition to family members who are going to be distressed by seeing their loved one who's developmentally disabled suffering with unrelieved pain, caregivers are going to have important impacts as well. Because if you're working with a group of developmentally disabled people and one of them, for example, is having an ongoing problem with chronic pain symptoms, that patient is going to soak up a lot of staff time. So the other developmentally disabled people in that treatment facility or group are going to get less staff attention and perhaps less than they might ideally need to implement their treatment plans or permit them to function at the maximum possible level.
So we're going to talk about the general principles of pain. When we talk about pain and people who have developmental disabilities, we're talking about a group of people who have any degree of severity of a developmental disability, an intellectual disability, autism, or anything on the autism spectrum, and developmental delays. The healthcare provider responsibilities regarding those who have pain and a developmental disability is in three main areas: the ethical area, the medical area, and the legal area. Ethically, we have a responsibility to understand that people who have developmental disabilities have a very different format for what's going on with their pain experiences, and that's what this whole set of modules is about. So ethically, you are doing exactly what you need to be doing in terms of pain in people who have DD. The medical responsibilities really morphs into every single discipline. It makes no difference whether you have a medical license, a nursing license, a social work license, a psychology license, whether you are a behaviorist. It doesn't really matter. We all have to acknowledge the medical impacts of both the developmental disability and the pain situation that the person is exposed to. And those medical realities are something that we're going to talk about a fair bit today, but also in our assessment and in the Module 3, which is the management of pain. And then the legal issues are, what are we keeping in mind in terms of being providers of care on a full spectrum of people who have pain and developmental disabilities. We are responsible for providing care in a way that fits what we know in terms of the most recent research and what is generally available in the literature. And that's what we're going to be providing for you, is the latest research and the latest ideas. Because that's, when it comes right down to it, that's what we're legally responsible for. When you're called into any kind of a legal situation, even if it's just discussing a set of circumstances, maybe some untoward circumstances with family members, and it might go into a legal situation, you want to know that you have the best, most up-to-date information available to you so that you feel comfortable with the kind of care that you're giving.
So since we had some technical glitches launching this seminar, maybe I will cover some things that you might be wondering about, like how long are we going to go on talking before we get a break? And that's going to be about another hour and, or so, and then we'll have a 10-minute or perhaps 15-minute break, and then we'll go for another hour and 15 minutes or so. And there is always room for questions, as was mentioned by Lisa. So with that critical information in mind, we can take some more look at pain symptoms, and we can divide them, for example, into acute pain symptoms and chronic pain symptoms. Acute pain symptoms are usually of recent onset. They usually last for less than 6 months or less. And there's an identifiable cause to them. There's some injury or something has happened to cause pain. And they tend to be transient, or as the cause is remediated, maybe the injury is treated, the medical cause is remediated, they tend to go away. Chronic pain, on the other hand, is persistent, so it lasts certainly 6 months or longer, and there tends not to be any trend towards improvement. In fact, often chronic pain syndromes, unless there's an effective intervention, will get worse over time. So for example, we had a 47-year-old male Down syndrome patient who broke his ankle, unfortunately. And for a while, he had what we would have regarded as acute pain. So he had pain from his broken ankle, and initially it seemed like putting the ankle in a cast and helping him with related treatment was effectively addressing the pain. But other factors intervened, and what some of these other factors are we'll get into as this workshop proceeds. And so the pain lasted. It was persistent, even beyond the point where by all medical assessment techniques, it looked like the ankle was healed. The patient continued to complain of pain. And it didn't seem correlated with the medical findings. And so it turned into a chronic pain problem. As you would imagine, that's when we were called it. So developmentally disabled people are at higher risk for acute pain. That's the shorter term version, because various features of their developmentally disabled syndromes predispose them to more accidents, for example. So let's take, as an instance of this, an older Down syndrome patient. Older Down syndrome patients, let's say in the 55 to 60-year-old range, have probably an 80 to 85% probability of developing symptoms of Alzheimer's dementia. One of the features of Alzheimer's dementia is a symptom called, technical term, apraxia, everyday English, difficulty performing well-learned movements. So, for example, the person could be in the kitchen and have some trouble executing movements that they may have accomplished successfully many times before, but now they've developed some apraxia, and they may have an accident in the kitchen, cause an injury, and it puts them at greater risk for acute pain. Also, another example of this, many developmentally disabled people have sensory or sensory integration issues. So, for example, a person might have problems with their vestibular system or their proprioceptive system, which are two sensory integration processes which enable the person to keep their balance and move through space and position their bodies appropriately in physical tasks. And so people who have problems in these sensory integration systems are at greater risk of falling. And of course that can cause injuries which can lead to acute pain. Chronic pain in developmentally disabled people is often a higher risk issue, in part because there's usually some unfortunate great amount of time between the time the person develops the pain problem and the time the pain problem is treated. And in all too frequent the case, this amount of time is sufficient so that the functioning of the pain nerves changes and the pain nerves start firing more frequently and repeatedly, and that puts the person at risk of a chronic pain syndrome. So if we take a look at chronic pain in general, we see that another way to examine the causes is we can divide chronic pain up into three categories: nociceptive, neuropathic, and functional. So nociceptive causes of chronic pain are, as the slide indicates, basically tissue injury or some kind of disease an accident that results in injury, a progressive medical condition. Neuropathic pain can include changes in the functioning of the nervous system. Now, this can be a result of damage to the brain, spinal cord, peripheral nerves, or a change in function of the type that we were just talking about, where the functioning of the network of pain nerves changes due to undertreatment of acute pain, which sets the person up for chronic pain syndrome. There are also functional, what we refer to as functional causes of chronic pain. There are emotional causes. So, for example, people who are clinically depressed are more likely to have pain symptoms than people who are not clinically depressed. There are psychiatric causes. There are some varieties of psychiatric conditions, and we'll touch on them a little bit down the road here in this workshop, which can predispose the person to having more pain symptoms. And there are behavioral causes, which basically relate to what is the person being reinforced for in terms of their day going along. And unfortunately, sometimes can happen even by accident, that the person is being positively reinforced for developing pain symptoms and reporting pain symptoms. And that may sound somewhat counterintuitive, but as we detail this, we'll see how this can come about. So when a developmentally disabled person has a problem with pain, it usually includes several of the factors that we've been talking about, because we know that developmentally disabled people have, in general, a higher incidence of physical or medical problems than non-developmentally disabled people. For example, in Down syndrome, we often see gastric problems and digestive difficulties, particularly as they age. And so we expect a higher frequency of gut pain or stomach pain or sensations of that sort. We know that developmentally disabled people are at risk for neuropathic pain because often they're not adequately treated for pain. And we have already mentioned the functional causes. People who are depressed, for example, will be more vulnerable to pain symptoms. You know, it's kind of interesting. You can take two groups of people. One of them has a clinical depressive syndrome, and the other group does not. And you can give them all flu shots, which is pretty much a routine stimulus. And the depressed people will report greater pain from the flu shots than the non-depressed people. So this affective depression also works in developmentally disabled people, unfortunately. The worse they feel emotionally, the more vulnerable they're going to be to pain and pain syndromes and pain symptoms. Sometimes we also work with developmentally disabled people who have a prior history of chronic pain problems, and we note that the chronic pain issues are exacerbated or they get worse. Now, when we say that chronic pain gets worse, we have to then ask the question, how do we know? What do we mean by a chronic pain syndrome is well controlled, or what do we mean by it's getting worse? So in order to know that, we have to do some pretty detailed assessment of what's going on with the chronic pain syndrome. And this is variables like pain frequency. How often does the pain happen? How intense is it when it does happen? How long does it last during pain episodes? Where is it located? Where does the patient feel the pain? Well, you know, physically where? But also, in what circumstances does the pain occur? Does the patient feel pain more earlier in the day or later in the day, during some activities or during other activities, when resting or when doing things? And what is the effectiveness of any pain treatments that we have going on for this particular developmentally disabled person? Is the pain medication working? Are there other behavioral or supportive therapeutic interactions that have been planned for this person, and how well are those working? And once we have an idea about all of those variables, then we look for changes in the negative direction to let us know that there's been a chronic pain exacerbation. So hopefully that points up the need that when we're working with a chronic pain problem in a developmentally disabled person, we need to do careful ongoing assessment. There's no way to track all these things without doing careful ongoing assessment. And the assessment needs to be done by everybody that works with a developmentally disabled person who has a chronic pain problem. And frequently when we see the exacerbation of a chronic pain problem in a developmentally disabled person, we have to look at all these different areas to try to find the cause or causes. And usually it's a list of causes rather than just one cause. So we're looking for a perhaps worsening of a medical problem, or we're looking at a change in the person's emotional state. There can also be a change in sensory function. Previously we were talking about the fact that many developmentally disabled people have sensory or sensory integration issues. So, for example, some people who have hearing problems use their eyesight in a compensatory manner. They may do a little bit of lip reading when they're in a conversation to understand what's being said to them. If the hearing problem worsens, they're going to have to be using the eyesight more. They're going to have to stare more intently to compensate for the loss of hearing. For example, that could lead to eye strain, could lead to headaches, could lead to neck pain. So sometimes changes in the way sensory functions are operating for the individual developmentally disabled person can result in a pain problem. There can be interactional factors. As I mentioned before, the patient might be accidentally reinforced for positively reinforced accidentally for pain symptoms. And some people have, technical term, a degree of alexithymia, now in English. They don't talk easily about emotional distress, and instead they tend to translate that into talking about physical problems when they're emotionally upset. And we'll detail that a little further in a few minutes. Then there are psychiatric factors. You know, there are some psychiatric conditions where pain problems and pain complaints are more likely. And if the person has a premorbid history or a prior history of the psychiatric issues that we're referencing here, if one of those psychiatric issues starts to act up again, then we have a possible contributor to chronic pain exacerbation. So by now, if you haven't gotten the message, and I'm sure you have, we can conclude that pain is a very complex phenomenon. And there are all of these different contributing factors that can lead to the exacerbation or creation of a chronic pain problem. So what does this mean for the treatment team? It means that the business of assessing and coming up with interventions for the patient's pain problem is not the exclusive job of the physician or the pain problem consultant, but everybody on the team, nurses, social workers, therapists, mental health aides, psychologists, psychiatrists, everybody is going to need to be monitoring and assessing how the developmentally disabled person is doing vis-a-vis their pain. And everybody is in the position to make productive, constructive, and helpful recommendations about how to change the treatment plan or things to add to the treatment plan to help the developmentally disabled person get the best possible result from their treatment plan that's targeted at their pain symptoms. Some of us are old enough, perhaps, to remember that when we got a referral for a developmentally disabled person who was developing a pain problem or suddenly they have a pain problem, we used to ask the primitive and outmoded question, well, is it really a pain problem or is it all in their mind? And so as you could see from this point, from the points we've been making, it's not so simple. We have to look at all of these different functional domains, behavior, emotions, cognition, interactions, physiology, for example, to figure out.
Welcome to GoToWebinar, Webinars Made Easy.
Issues. If we just ask, is
Welcome to GoToWebinar, Webinars Made
are practicing as it was popular 40 years ago, and it's outmoded. So with that in mind, rather elegant and mysteriously compelling, Dr. Triggerboff and I have come up with an acronym, MESIP, and this is a way of thinking about all of the factors that you have to look at if you're going to competently assess the developmental worsening of a pain problem in a developmentally disabled individual. So you're probably wondering what these letters stand for. And they stand for medical, environmental, sensory, interactional, and psychiatric. This is an acronym that we like. You can make up your own if you'd like, but it should cover all of these points. So when we have a referral of a developmentally disabled person who has a new pain problem or worsening of one that was there before, we look for medical causes, we look for changes in the environment or environmental factors, we look for changes in sensory functioning, we look at interactional factors, which is a fancy way of saying, so is there positive reinforcement now for the patient to complain of pain and report pain symptoms? And often we find something like that. And finally, we look at the psychiatric history, current psychiatric symptoms, previously diagnosed psychiatric problems, and are any of them exacerbated? Yeah.
So pain in general with people who have intellectual or developmental disabilities needs to be updated on a regular basis because things are coming out quite often. Studies show that pain in this population is not properly treated, that many times people make assumptions. Anybody makes assumptions about somebody who has a developmental disability and what's going on with them because they're not as verbal or they're verbal in a very particular bracketed way of being that isn't the same as people who don't have a developmental disability. And so people make assumptions that they don't feel the pain as acutely, that they don't feel pain at all, that the kind of pain they're feeling is really not something that you have to treat in any kind of medical way. And these are really disturbing and pervasive assumptions that people have made about pain for decades. So for the long run, we need to take a look at who's new to the business and who's been fairly established in the business of providing services to people who have developmental disabilities and try to address any assumptions that have been of long standing, because the studies show that it's just not being done well, and which is one of the reasons why we're doing these kinds of presentations. This population also requires medical treatments and interventions that are quite painful, and they've been developed over the past decades, usually based on assumptions that, well, maybe they don't feel it quite as acutely, so it's not going to be that much of a problem, it's not going to be that much of a bother. But because people who have developmental disabilities are very much more prone to having medical problems, they're much more likely to have GI problems, they're much more likely to have seizure disorders, they're much more likely to have diabetes and cardiovascular problems. All of these things require interventions that are not all that comfortable to have. So we are frequently imposing painful situations on people who have developmental disabilities. So for example, an equivalent surgical procedure, somebody who has a developmental disability is usually given less pain med than somebody who has exactly the same procedure going on, the same surgical procedure, who doesn't have a developmental disability. So just the fact that these people have these diagnoses means that they're not going to be getting the full range of help that we can give as healthcare providers. So basically that's called undertreatment. So how do we know someone is in pain? Now in the next module we're going to talk about specifically how you make these assessments. But the general idea about pain and developmental disabilities is what are people's reactions to pain? There are vocal reactions. The pandemic ow is a good one. But what if somebody isn't particularly vocal? Or what if they can't form that phoneme because of the way their tongue is attached to the base of their mouth? There are emotional reactions to pain. Some people get very sad when they're in pain because it bothers them, it hurts them. Some people get mad when they're in pain, so they have this emotional reaction that they become furious when they're in pain. And you don't necessarily know that that's what's driving that emotional reaction, so we have to interpret a little bit. Facial expressions are usually a good indicator, but what if the face is masked in some way? They might have Parkinsonian syndrome, either naturally occurring or drug-induced as a side effect of antipsychotic medication. So a facial expression sometimes does not do it. If they have tics, facial tics, or dystonias of some kind, or even a dyskinesia. A dys is bad in medical terms, as I'm sure you all know, and kinesia is movement. So a bad movement can be spontaneous with the face. It can happen with people who have schizophrenia. People who have developmental disabilities are at a higher rate of schizophrenia than people who don't have developmental disabilities. And there are stereotypical facial expressions that can go along with these different diagnoses. So they might have facial grimacing that's just part of the diagnosis, and we don't know whether the facial grimacing is also backing up some pain reaction. There are protective reactions, nonverbal protective reactions, where people will flinch or they'll brace in some way, they'll tighten up their muscles. There are body movements where people kind of hold themselves in a particular way. And there are physiological signs. Blood pressure can go up, heart rate can go up, respiratory rate can go up. People can pant in a very shallow way when they're in pain, or they might try deep breathing to try to ride through the pain. But we have a question. Is that right? We have a question that we can address at this point? And questions throughout are good. We'll just try to break in and do them as it becomes easy for us to do those. You can go ahead and ask the question. Your microphone should be unmuted so that you can do that.
Susan?
All sorts of fun with our technology today.
Hi, Susan Blasius. You can go ahead and ask your question now. You're unmuted.
Oh, I'm sorry. I wanted her to talk up louder or turn the volume. I was having trouble listening to the last part.
Oh,
when you talk out. Okay. Thank you.
Okay. Now, can people hear me now? Well, I'll keep going, and Lisa will tell me, to speak up or shut up. And I take direction very well, as people will tell you. So we're going to talk about pain impacts. Severe pain does more than just hurt. Severe pain has an impact on not only your body, but also your emotions and also how you think. Pain is not a good neurotransmitter. So you're not going to be able to problem solve as well. And I'm sure you've all had the experience of being in pain. You've had a headache, or you've had a terrible cold, and you have aches and pains. That is not the time to work on a calculus problem, or for somebody to say something very complicated about a behavioral plan, and you got to come up with something creative to respond to it. Pain interferes with the way you think, the way you feel emotionally, psychologically, and in the way you perform your duties. So pain really does interfere with a lot of aspects of your life. It affects your mood, it affects your appetite. Some people don't eat when they are in pain. These people I don't understand. Some people will eat a lot when they are in pain because they're trying to soothe themselves, and they usually eat things that are beige, the comfort foods, mashed potatoes and gravy, macaroni and cheese, cookies, cakes, candies, things that are beige tend to increase our serotonin levels artificially, briefly, and that makes people feel more comfortable, although sooner or later they're not going to feel so good about it. And it interferes with your ability to function in all aspects of your life. It can induce irritability, it can make people crabby, it can make people sad, it can make people anxious. They might have feelings of fear and anxiety about the pain. What does the pain mean? Does the pain mean I'm going to die? Does the pain mean that I'm going to lose my leg? Does the pain mean that I'm not going to be able to go do something that I was looking forward to doing? So that can raise the anxiety level. And once you raise it, it's very hard to bring it back down to baseline. People can become agitated when they're in pain, or they can withdraw and just pull into themselves and become more in a shell. And some people get physically aggressive. They act out when they're in pain because they just don't have the self-control, because the pain has eaten away at their abilities to do that. So you need to know the basics and the intricacies of pain. We're focusing on these 3 modules and increasing the awareness of service providers having about pain in people who have developmental disabilities. It is different. When you have a DD and you got pain, it's different than for the rest of the population. You have to consider all of the components contributing to the pain situation, and you have to conceptualize the process of long-term and short-term pain, what's going on with the acute levels and the chronic pain levels. And to add to the complexity of it, sometimes you can have an acute pain from one set of circumstances and a chronic pain situation from another set of circumstances, and you have to weave together a comprehensive plan about that. And of course, the intricacies are as the fabulous and magnificent other Dr. Triggerboff said, the nociceptive, the neuropathic, the functional pains, and always keep in mind the acronym MESIP, medical, environmental, the sensory, the interactional, and the psychiatric aspects of pain. The trauma that people have from time to time can involve pain, and many times people who have developmental disabilities have had a great deal of trauma. As a matter of fact, recently we've had a great influx of people who've been referred for therapy for post-traumatic situations who happen to have developmental disabilities. People are much more prone to being victimized when they have any kind of problem with a developmental disability or a psychiatric disability, certainly both. DD recipients, if they've been traumatized, may have been physically hurt during the trauma, not just emotionally disrupted. And the trauma reactions that people have, post-traumatic stress disorder or just trauma reactions, acute trauma reactions, can include re-experiencing or having flashbacks of this specific trauma, which means that they also might re-experience the exact pain experience if they were being beaten, if they were tripped, or if they were pushed down a flight of stairs, or if they were raped or somehow abused in some way. That pain, the actual pain, can happen again as they re-experience it. It can be triggered by a similar pain. So let's say, for example, that somebody had been beaten during a traumatic experience 2 or 3 years ago, and I'm just using this example because we most recently had this consult that we did, and recently the person had a medical procedure that was a little uncomfortable. The pain was not excruciating by any means. We knew that she was able to handle pain like this before she had had the trauma 2 to 3 years ago, but because that trauma had occurred, that pain that she had from this medical procedure re-experienced all the pain she had from the beating. So she got to experience all of that again from a very minor set of circumstances in the current situation. But of course, post-traumatic stress disorder doesn't care about a timeline, so it popped her back into her trauma. It can be, pain can be a trigger for psychological re-traumatization. It can be a trigger for them. Pain in any area can evoke previous trauma reactions in another part of the body. So if someone has a dental problem, but they had fallen down the stairs at some point and that had traumatized them, it could cause them deep bruising and some bone bruising, the dental problem might kick off the pain memory that had happened from another injury. It can, in general, promote a feeling of helplessness, that there's just nothing you can do, and victimhood if the person had been traumatized before. And this is not particular to people who have developmental disabilities. It happens with everybody. The pain, it's possible to feel helpless when you have had unremitting pain. It can weaken somebody's resolve to move past a trauma. When you have post-traumatic stress disorder and you're having a painful experience and it is triggering you all over the place in terms of re-experiencing your pain, sometimes people just give up. I just can't do this again.
So let's focus a little bit more closely on psychological impacts of pain with regard to major psychiatric symptoms of significant psychiatric and psychological disorders. Let's start with hallucinations. So hallucinations are experiences where the person sees something that isn't there, hears something that isn't there, smells, tastes, or feels something that isn't there. So these might be symptoms, for example, of a psychotic disorder, or perhaps the person, developmentally disabled person, has a history of schizophrenia. And unfortunately, often with treatment of schizophrenia, hallucinations don't completely go away. And so often the patient is left in the position of having to manage, to learn skills to manage the occurrence of hallucinations while continuing somehow to perform activities of daily living, work functioning, social functioning in as adaptive a manner as possible. So these skills that the patient has to learn to cope with these ongoing hallucinatory symptoms can be degraded by ongoing problems with chronic pain. So that's kind of a long and roundabout way of saying that if a person has trouble with hallucinations and a developmental disability, the occurrence of a chronic pain problem can reactivate or worsen the ongoing problem with hallucinations. Similarly with delusions. Many delusions are of a paranoid sort. The person feels like they're being persecuted, followed, watched, conspired against. Some of the more severe paranoid delusions, the person may feel like other people at a distance are doing things that cause changes in their bodily functions, negative kinds of changes. And feeling pain is a prime candidate to be incorporated into those delusions. Or to say this another way, a person with a developmental disability and a problem with paranoia who thinks that other people are trying to do bad things to him or her, when they feel pain, they may become convinced that the pain symptoms are the result of the other people or a result of the conspiracy of people trying to do bad things to them. So it makes coping with those delusions a lot more difficult. We have a kind of a positive feedback loop that people can get into with depression and pain. We know that people who have chronic pain are more vulnerable to depression, and we know that people who are depressed are more likely to experience pain problems. So frequently people who are depressed and have a developmental disability, when they have chronic pain problems or the onset of a pain problem, it worsens their depression. And in a somewhat similar manner, it can worsen mood instability. Many times when people have pain problems, it causes a release of an elevated amount of adrenaline into their systems. It's a noxious stimulus, as we say in Psych 101. It results in increased release of adrenaline, and this is going to act to increase anger, anxiety, fear. So if the developmentally disabled person that you're working with has a history of anxiety problem, let's say, for example, obsessive compulsive disorder or some sort of phobia, or even perhaps an impulse control problem, the extra adrenaline resulting from the ongoing pain problem is going to power up those symptoms in a negative way. So this can be a significant psychological impact of pain symptoms in a developmentally disabled person. And let's just sort of finish this slide by looking at impulsivity. Some developmentally disabled patients have problems with impulsivity and with restraining themselves from doing or sometimes saying certain things that are not adaptive. So many times we have worked very hard with the developmentally disabled person in this category to develop skills at restraint. And neurologically speaking, restraint is one of the most complicated things that we do cognitively. So therefore, it's pretty easily disruptible. And pain symptoms are something that can disrupt the neurological and the neuropsychological process of maintaining restraint. So if we're working with a developmentally disabled person who has an impulsivity problem, or what we used to call perhaps an impulse control disorder, that's likely to be worsened by the occurrence or worsening of pain problems. Pain, through its psychological and physiological impacts, can also worsen medical problems. So for example, if we have a person who has a problem with respiratory distress, like somebody with asthma, Down syndrome person with asthma, or even COPD, if the person develops or worsens a chronic pain problem, as the other Dr. Triggerboff pointed out, they're going to be more likely to breathe irregularly or even to gasp in pain, and that's going to worsen respiratory distress. An older Down syndrome patient, yet once again, to kind of repeat an example, may be at high risk for a gastrointestinal problem. Now, if they develop or worsen a pain, that's going to increase gastric motility. And in a person with gastric problems, that's going to increase gastric pain. So into other impacts that will worsen pre-existing medical problems. So pain drains our psychological resources. And it does that not only for somebody with developmental disability, but also for all of us in general. For example, when was the last time you went to work with a lower back pain problem, or your knee hurt, or you had a headache, and then you came home at the end of the day and said, gee, that really helped me get my work done today, having that pain. And I'm really glad I had it. And my interactions with my coworkers and my family and my friends, they were all great because I was in a lot of pain. I know I've never had that experience. And your developmentally disabled people that you work with have never had that experience. And many times, developmentally disabled people have worked very hard to develop the skills that they have in working or getting along with other people, and the psychiatric drain, the drain on the limited psychological resources of that person that an ongoing pain problem will produce is not going to do them any favors in terms of trying to maintain the quality of their lives.
So as we have indicated, pain is stressful. It is a stressor, and when somebody has a stressor, it makes a lot of ripple effects in what's going on with the individual. It's a physical stressor. It'll affect your heart rate, your breathing rate. It'll affect your blood pressure, mostly because you have adrenaline, there's epinephrine, that's jacking up your system. So you're going to be tenser. You're not going to be mellow. You're not going to be loose. You're not going to have this kind of malleable physical existence. So it's tough as a physical stressor. It is a psychological stressor, as we mentioned, because you're just not the same person that you were. The other psychological aspect to it that we'll explore a little bit more when we're doing the third module of pain management is that whenever you learn something new as a coping mechanism, a new psychological trick that you can put into your toolbox, it is a new one, and therefore when you are put under pressure, you're likely to regress back to the last thing you used as a stressor, a stress management tool. And so if you have a new set of coping mechanisms in place, when you're in pain, that's going to rip that out of place. It's going to take it out of position, and you're going to see a regression back to a previous form of coping. So psychologically, the person is constantly going to be challenged and reminded that they are doing a very good job, that they are not progressing as they thought they were, so they can start to feel like, oh, why am I putting so much energy into doing this new coping mechanism when it doesn't work? I'm in pain. So they'll drift back to something previous. So it's a psychological stressor for sure. It's a behavioral stressor because many times what we're doing with people who have developmental disabilities is we're teaching them how to have behavior that's more appropriate for their circumstances, how to do the right thing under different circumstances. Not if somebody is sitting in their spot on the couch to yell at them and say, that's my seat. You know, we're teaching them behaviorally to say, first of all, to themselves, I can go sit someplace else and it's okay, but also to say pleasantly to somebody, would you mind if I sat there? And to be more pleasant and interactive about it. But when you're in pain, your behavioral repertoire is going to be more rugged and ragged. Cognitively, you're going to be different because you have a drain on your abilities to think and to problem solve, and you're not going to be able to problem solve as well, and you're not going to be able to think as well. And if you were just taught a new way or an unfamiliar way, you're trying to find your path through this new way of thinking, it's going to be challenged to a great degree. The physiological impacts of pain we've talked about. It's going to worsen your vital signs. Hypertension is going to be exacerbated by pain. Even a normal blood pressure is going to be heightened by pain. We know that blood pressure can be heightened just because somebody in your environment puts on a white coat. We call it white coat hypertension. You know, sometimes I don't even have to put on a lab coat, and I go to take somebody's blood pressure and it shoots up. It's because I'm so frightening as an individual, so imposing, I guess. But you know, we know that your blood pressure can be very much affected by your emotional situations. Your breathing can be shallow and fast, as I mentioned before, and your heart rate will change. Your heart rate will go up. It can distract the client from coping with other physical problems. So for example, the young man we had who had a broken ankle, he had to deal with this broken ankle. He had to have time when he was not weight-bearing. He had time when he had to learn how to deal with the crutches and not use the crutches as a weapon, as a way to get somebody to move off of his seat on the couch. So there were a lot of new copings that he had to do because of this physical problem. So if exercise, posture, certain movements are needed to treat the problem or to prevent there being a problem as the physical challenge is resolving, or to support a physical problem, the person might just not be able to do it. It might not be reasonable to ask somebody in pain to not do something that they would normally do. The pain can dislodge what is eaten, the expenditure or conservation of energy. It can dislodge medication times. If the pain makes somebody nauseous, sometimes pain will do that. It kind of crosses over a threshold from just being a certain kind of pain to pain and nausea. It actually can make it impossible for that person to take the medication that they need to take, especially if it needs to be taken with food. For example, Geodon, which is an antipsychotic and or mood stabilizer, as you see, needs to be taken with food, and it's taken twice a day. So, and it needs to be taken with at least 500 calories of food, so it can't just be taken with a couple of crackers. It's not going to metabolize and be bioavailable as well. But if the person's in a great deal of pain and there's no way they're getting 500 calories into them, then we know that the Geodon is not going to be as effective. So the things to keep in mind are the physiological impacts of pain. It can impair all of your efforts to evaluate what's going on with their medical treatment. So they're getting a medication for hypertension, but they're in pain, so their blood pressure is up. Does that mean that their antihypertensives are not working, or they're not working well enough or consistently enough? So the accuracy of all of the assessments and evaluations we do can be reduced. And in Module 2, we'll talk more about that. Reducing one pain problem might bring to the surface a different pain problem. It's called gating. So if somebody had a terrible toothache and you're dealing with it and you're dealing with it and you're dealing with it, and you finally resolve this terrible toothache, and now the person is complaining of, you know, like terrible pain in their shoulder, it's not, gee, they just have this new pain. It might have been that the pain in the shoulder was there all the time, but the body was only dealing and the mind was only dealing with a certain amount of pain at a time, and the dental pain really took over for that period of time. You resolve it, and then this one can come to the fore. So in general, we're trying to increase the awareness about pain and all of its complexities. So just recognize the multitude of pain events that are possible for anybody, but especially for people who have developmental disabilities. Pain is experienced when somebody has an injury. And as a fabulous Dr. Turgelbach mentioned, people who have developmental disabilities are a little bit more prone to injuries. Some of it is a side effect of medication. For example, if you're on anti-epileptic drugs, AEDs, over time that can cause osteoporosis or osteopenia. So the bones are more fragile and more brittle, and it can be more likely broken. So you have broken bones, you have fractures, sometimes micro fractures, sometimes green stick fractures. Might not be immediately apparent, but the person has an injury that happens more likely because they have this developmental disability and they're going to have pain from it. There can be pain following an injury. So let's say they're just more impulsive and they're just acting in a just more jagged way in the way they're moving, and so they're going to fall down and they're going to hurt their knee. And afterwards, the knee is just absolutely in agony. It might not even be all that swollen, but there's something going on that's going to cause pain following an injury. There is debilitation that occurs with pain because the person psychologically, physically, emotionally is all going to be worn out by it. Only during use of the debilitated body part. So let's say somebody has some pain in their shoulder and it doesn't really bother them when they're holding still, but when they go to eat or when they go to write or they go to talk to somebody and they move around a lot when they talk, that's going to hurt them. There's something called anticipatory pain. You know you're going to get an injection, you know it's going to hurt, and so before you get the injection, you feel the pain. We have a lot of muscle memory, neurological memory of pain to a certain extent, and we can have anticipatory pain as a result of that. There's intermittent pain from muscle spasms or shifting of pressures or how the torque is working, especially with the high spasticity that's present in a lot of people who have developmental disabilities. Is adrenaline contributing to the delay in pain? We know that people who are very agitated and acting out can do something like punch a wall or kick something, and it seems like they don't feel that amount of pain. But afterwards, after the adrenaline settles down a little bit, that's when they start to feel the pain. They broke their hand, or at least they stretched a ligament too far. So the adrenaline the person feels might delay their experience of pain. And we talked about masking, gating, and then there's the triggering from traumatic experiences that can happen. So along the lines of increasing the awareness about pain, how is pain level determined? What is the time of it? When is the person feeling the pain? How severe is it? And there's lots of ways to characterize that. I personally am very much a numbers person, and so I tend to say, okay, 0 to 10 in my mind. What's 0 pain or 10 is the top of the scale. What's happening at the same time as the pain? Sometimes it can be a visit from somebody who's kind of obnoxious. Sometimes it can be they're eating something that previously they had some difficulty with. What happened before the pain and what happened after the pain? And what's the individual's pain threshold, which the other fabulous Dr. Triggelbach will go into. And then we mentioned gating before.
So in addition to all of this, it turns out to be the case that all of us, whether developmentally disabled or not, have personalities. And some features of those personalities that we all have can play into how pain is experienced and reported. So the current range and models of personality is what's called the 5-factor model, and that's because, cleverly enough, it includes 5 factors. You can see them labeled on the slide here. And we have typically used the acronym CANOE, C-A-N-O-E, to refer to these factors, and we'll talk about each one a little bit and how they can relate to pain problems. But it's been pointed out to me that you can also spell ocean with those letters. So pick your acronym, CANOE or ocean. I kind of like CANOE because it reminds me that we're all paddling in the same boat of personalities and personality features. But if you like ocean better, then you can sort of think about we're all swimming in the same ocean of personalities and personality features. But let's go with CANOE. So the first letter in CANOE, C, is conscientiousness. Some of us are very planning-oriented and very much making contingency plan and doing everything we're supposed to, and studying up on things and rehearsing and practicing. And a conscientious person, or a conscientious person even with a developmental disability might be more likely to report pain when it's experienced than someone who is more laissez-faire and takes things as they come and whatever kind of orientation might be less likely to report pain symptoms. And it makes it important that if we're working with a developmentally disabled person who we think might have a problem with pain but is less conscientious, makes it important for us to do a little bit more work with that person on assessment so that we don't miss the occurrence of a pain problem and then that pain problem goes undertreated. And similar idea obtains to the next one on the list, agreeableness. Some of us are very agreeable just in general. Life is a good experience, and whatever happens that's new or different, we like it. And then others of us tend to complain a little bit more. And Someone who is agreeable, a developmentally disabled person who is more agreeable, may not react much to the occurrence or worsening of pain symptoms because they tend to more or less accept or even like everything. And so if we have someone who's developmentally disabled and we know about them, they're more agreeable, we suspect they might have a pain problem, we have a little bit of extra assessment we have to do in that case. The third variable is neuroticism. So people who are high on the neuroticism scale tend to be people who are going to have issues. Occurrences make them nervous, occurrences make them angry, they get perhaps sad easily, there are issues. And people who tend to be higher on neuroticism scale tend to be people who will report pain symptoms more and have more issues about pain, like they have more issues about everything else. But if we have a developmentally disabled person who is relatively low on the neuroticism scale and doesn't tend to have a whole bunch of issues, but we suspect about them that they might have a pain problem, maybe they've had an ongoing illness that looks worse, or a medical issue, we have to do a little bit of extra assessment here because the person low on the neuroticism scale may not report pain adequately. The fourth variable is openness. Some people seek out new experiences, new ways of doing things. And other people are more closed, so they avoid new experiences or changes in routine like they would avoid the plague. And someone who is more open to new experiences, if they develop a problem with pain, might be less likely to report it because it's just another new experience. But a closed person who has a routine that they like to follow every day and not get disrupted, that's a person you may hear more from about pain. So if you have a developmentally disabled person that you're working with who tends to be more open from a personality perspective, and you suspect about that person they might be developing a problem with pain, you want to do some extra assessment there. And the final variable in the five-factor model of personality is extroversion. So some of us really like other people, we like being around social situations. Gee, people are just great, can't get enough of them. And other people are a bit more introverted, so that they tend to gravitate more towards solitude or fewer social experiences. They're okay on their own. An extroverted person, because they interact more, might be more likely to be someone you'd hear about pain problems from than an introvert. So if you have an introverted developmentally disabled person that you're working with and you have reason to suspect that they might be developing a pain problem, or maybe you're already managing a chronic pain problem with an introvert, you need to do a little more assessment there. We need to do a little more assessment to make sure we're not missing anything. And some of the developmentally disabled people that we work with have personality trait disturbances or even personality disorders. So how do features of personality disorders interact with pain problems in people who are developmentally disabled? So the first category is developmentally disabled people who have, technical terms, histrionic or somatizing personality traits. Now, in plain English, a histrionic person is somebody who's very dramatic, very flamboyant, kind of makes a Broadway production or Broadway show out of demonstrating symptoms. So if we have a developmentally disabled person that we're working with, we know about them from other venues that they tend to be histrionic, we can expect that their pain complaints when they have a pain problem will similarly be histrionic and very dramatized. And that should play into what you conclude about their pain symptoms. Some people do what we call technical term somatized, or somatizing now in simple English. They convert psychological distress into physical symptoms. So if we know about the developmentally disabled person that we've worked with, in the past, when they've had emotional issues, they've tended to express that through somatic complaints, complaints about pain, complaints about medical problems, and we see that person is currently showing an increase in somatic complaints. One possibility is that they are having an increase in the pain problem. Antisocial personality disorder people are very likely to use pain complaints in technical term and instrumental way, English, to get things that they want. So if they don't want to go to a therapy group, all of a sudden something is going to hurt. Or if they want more pain medications, you're going to see more pain complaints. Or if they want something else like interaction with a new, young, attractive staff member, they're going to make more pain complaints when that person is around, perhaps. So instrumental use of pain or using pain to get something that they want. If you see that in a developmentally disabled person that you're working with, you might suspect antisocial personality traits. And similarly, if you know about somebody already that you're working with that they have antisocial traits, if they then develop a pain problem, these are the kinds of features you would expect to see with their pain complaints. And finally, everybody's favorite borderline personality traits, or borderline personality disorder, among the many kinds of symptoms that these folks will tend to manifest is staff splitting. So this is where you get one faction of staff fighting with the other faction of staff about what's the best approach to help them with their pain complaints. And if we see that, if we see discord developing in staff about a person's pain problem, we might suspect the possibility here is that they have borderline traits. In the old days when we had paper charting, we could just weigh the chart, and the heaviest chart usually was from a person with borderline traits. I suppose now you would have to look and see which electronic chart takes up the most computer memory. That's the person who is at most risk to have borderline traits. So in such a case, staff has to work really diligently so that everyone's on the same page about how to react to pain complaints and pain problems in a developmentally disabled person with borderline features.
So along the lines of we're all increasing our awareness about pain that people with developmental disabilities experiences, there are structures involved in pain processes that vary depending on the diagnosis. People have different neurological organizations. Their neural pathways are different because of the variety of developmental disabilities that can happen. We know, for example, that people who have certain kinds of autism are going to have certain kinds of parasympathetic and sympathetic nervous system changes to what happens to their experiences in the world, which is certainly going to include their pain. Gastrointestinal changes, a lot of people with developmental disabilities, regardless of their diagnosis, do not have the same GI tract that the rest of us have. They're going to have more stomach problems, they're going to have more bowel problems, they're going to have more esophageal problems. They're not going to be able to metabolize things as well, and the GI tract has a lot of experience, pain receptors. So if the GI tract doesn't work very well, and the person has a developmental disability, and they have anything that's going to cause pain, all of that is going to roll up into a bigger problem. Perceptual problems, and not just hallucinations and delusions, but also sensory integration issues, sensory issues in general, are going to change the perception of the pain. Respiratory, people with developmental disabilities have an alarming rate of respiratory problems. They're very prone to respiratory problems. And there are a lot of pain receptors in the lungs themselves, so there's going to be some respiratory contributing factors. Skin sensations, also because of the sensory integration issues, and touch sensitivity. Sometimes some people are very tactile averse, or they actually have pain when certain things touch them in certain ways. You probably had the experience of somebody not being able to wear or refusing to wear a particular clothing item because of the way it felt. We had Temple Grandin present at a conference that we organized a couple of years ago, and she's very clear about how she's a woman with autism, high-functioning person, has a doctorate, and works very well, does a lot of public speaking, and she cannot wear certain clothing items because it actually feels like sandpaper against her skin, which includes underwear. So she has to have a very special set of experiences around the clothing items because her skin is so sensitive, and her skin actually interprets certain stimuli as pain stimuli. So, and that's not an unusual set of circumstances. A lot of people with DD have that. Joint and muscular pain also occurs. A lot of people who have developmental disabilities have rheumatoid arthritis, so there's going to be joint pain. A lot of people with developmental disability have spasticity problems, and not just from cerebral palsy, but any kind of muscular spasticity. And that stiffness from the musculature also contributes a great deal to pain messages. Once someone has, somebody who has developmental disabilities has pain, experiences that pain, there are a lot of ripple effects that happen as a result. There are feedback mechanisms. Something hurt, what happened as a result of that? And what are you going to do about that? What is the person going to manage in terms of coping? How do people in the environment act? The interactional, but also the medical and physiology impacts of pain. There are overstimulation challenges. So people with developmental disabilities can only handle so much information coming into their brain at a time. And the pain on top of that might be too much. The straw that broke the camel's back. So they get overstimulated and they just crump, which is a technical term for they just can't handle anything else. The reactions to pain, as we mentioned before, can be impulsivity because they just can't manage and control what's going on with them, so they just act out. Anger, sadness, fear, confusion, all of these things can happen as a result of pain. The consequences of these reactions in general is pain makes it worse. Anything that's going on with your psychological state is going to be disrupted. And you know that disruption with people who have developmental disabilities is bad. People who don't have developmental disabilities who are disrupted can have a difficult time. But this particular population is very sensitive to it. It disrupts their physical states. Something is as straightforward as epilepsy with the anti-epileptic medication, and they get stabilized. They have pain from some other region of their body, can actually make their anti-epileptic drugs less effective and their seizure control less effective. There's worsening of any psychological problem because they will regress to a former state of coping. There's a worsening of physical problems because we're so interactive with all of our systems. We don't have siloed systems or whatever is going on with your emotions. It has absolutely nothing to do with what's going on with your body. We don't work like that. You know, that would be too easy. So it's all intertwined. And then there's the interference with interactions and communication. Human communication is very complex, as we figured out when I'm not talking loud enough or we don't have the right pictures up. Communication is very complex. You add pain to that and it's going to make it less effective. It interferes with how somebody does their activities of daily living. Sometimes when you are in pain, you just can't be bothered to wash your face. You can't be bothered to comb your hair. You couldn't care less what you were putting on in your clothing. You just grab something. So it's going to interfere with that ADL level, which is, of course, going to interfere with previous learning and a sense of achievement. If they felt really good about being able to do something, and now they're in pain and they just don't feel like doing it, now they've lost that sense of achievement and that motivation that can go on towards learning more and more complex items. It changes the rates of behavior. If you had somebody who did self-stimming behavior to a certain extent and they were able to keep it under control, you add pain to the mix, now their rates of self-stimming are going to go up. Caregivers' attitudes and assumptions, what we think and what we assume about medication and pain and developmental disabilities and activities, all of that can take us completely off track. What do professionals think about pain and SIB, self-injurious behavior? What do we really think about that? What do we think about how people with developmental disabilities have a slow reaction time? Research shows that people who have a slow reaction time are actually interpreted as not being in pain because they don't express the pain immediately. They express it later. So most people, caregivers, say, well, I guess they don't feel that pain because they're not doing anything about it. Underreaction to pain routinely felt by others. There is an assumption made that people with developmental disabilities don't feel the pain as accurately or as properly as people whose neurological systems are designed in a slightly different way. And then, of course, cerebral palsy with the spasticity and the bracing that happens. Some people just don't think that hurts. Of course it hurts. If you've ever had a Charlie horse, now imagine having that spasm go on all through your body all the time. You don't get used to it. It just hurts. Components contributing to pain, injury, as we mentioned before, certainly chronic illnesses. People with developmental disabilities have a certain amount of chronic illnesses. So arthritis, osteoporosis, sometimes the osteoporosis is a standalone, sometimes it's a side effect of medication, diabetes, and gastrointestinal problems, the muscle spasticity that happens with cerebral palsy, but also with any other spasticity, and infections. Lots of infections. We'll have a great deal of fun talking about those later. But let's take a break for about 10 or 15 minutes, and we'll see you on the other side.